Welcome to my podcast. Today I'm going to talk about another common case can be seen in the clinical setting. So after you introduce yourself, as always you agreed, double check the patient name, date of birth. The patient will tell you, doctor, I'm having this sort of swelling and my cheeks, and it's been ongoing for the last few days. I had preceding tonsillitis or upper respiratory tract infection, and I'm not feeling myself. I just feel tired all the time. I'm having some sort of skin hotness. So in that condition, you need to inquire a little bit more. So you will ask the patient, do you have any thought what might be the reason for this presentation? Do you have any family history, same alignment? Have you been traveling abroad recently? Have you been in close contact with anyone who had the same symptom, for instance? Do you have a past medical history that I should have known about? And medication-wise, if there's any medication that you take. So the patient will say, yes, I do have a disease for which I'm treated and I'm okay. For the last 10 years, the patient says that they have Crohn's disease and they're inflexible and they're quite controlled. And apart from that, they're fit and well. They're working in a stable relationship and nothing more than that. So you'll tell the patient that I would like to have a close look on your rash. And on examination, you're going to find that the cheek is quite red and firm in touch. It's hot. And it has that feeling of peau d'orange. It's quite well demarcated and red in color. And also including the bridge of the nose, so basically the butterfly area. And you'll tell the patient would like to have a close look in your mouth. So the patient opened their mouth. There's nothing can be seen, whether in the tongue or the buccal mucosa or in the back of the throat. You'll tell the patient would like to feel for your neck. And you will establish that there is bilateral tender lymphoadenopathy. So from that concept, you need to think about your main differential. So as I say, it's a rash in the butterfly area. So in that condition, we need to think about cilia. Also, we need to think about polymorphic light eruption, fifth disease, which is called erythema plexuosum or slab cheek syndrome. And another thing is erysipelas. So the patient here, as we know, has Crohn's disease and is taking infliximab, so he's immunosuppressed already. So this will harbor any sort of infection, bacterial or viral. And the patient had tonsillitis in the preceding days, so we need to think about streptococcal. And as the patient says that he feels tired, and you check the temperature is mildly raised, so you need to think in that condition what might be aligning or clicking or in line with those presentation. So you could think of as well cellulitis, which is superficial form caused by streptococcal A beta hemolytic bacteria. And also you think about erysipelas, which is the difference between them both. Cellulitis is basically superficial diffuse inflammation. However, erysipelas, it will be sharply demarcated from the normal skin. And you know that any age can be affected, really, but The fifth disease is mostly in children, and it's viral, which is parvovirus B19. Also, you'll ask the patient if they have any history of recent travel or going for a beach and lying under the sun, which will align with the polymorphic light eruption. And the patient denies that. And also from the examination, you can tell, for instance, the V area of the neck, if it's affected or not, and underneath. And also, when I said about SLE, mostly in those kind of cases, they have GIT manifestation, and in this condition, patient did not stated any of that. So, from that regard, you will think about the risk factor. Obviously, in this condition, is immunosuppression. And if there is any disruption for the skin barrier, which will harbor infiltration and a route for the bacteria or surface bacteria to get in the body. So you will arrange for a blood sample for culture, just to confirm the sort of bacteria infected in this condition. And of course, you need to treat immediately at the case in order not to get worse or become systematically. So you need to arrange for systematic antibiotic, say for instance like cephalosporin or ceflexin, or clindamycin, or phenoxymethyl as well. And if the patient is severely presented, in that condition, you give antibiotic in the form of intravenous route. And as I say, the patient denied the sun exposure, so in that condition, you're not going to think about this one. However, if it was the case, the treatment is kindly as different, is about avoid the trigger, treat accordingly. So I hope by that I just shed light about one of the cases that you might see. Also, erysipelas can affect the lower leg, by the way, and will present with a sharp demarcation between affected and non-affected skin. So it's sort of condition that you could be presented in the clinical setting, and you need to know how to spot it and treat it efficiently and effectively. And also here in the UK, when you walk around, you could notice that in certain patients in their legs. So I sort of many times notice inflamed, swollen lower legs, and of course there can be a lot of differential in that condition based on of course the presentation and the manifestation of the patient and the past medical history, which all of that will help with the diagnosis. However, cases sometimes can be spot diagnosis just from the from visually you see it and you can spot the diagnosis. So I hope by that I shed light on one of the conditions that you might face in the clinical setting and how can you approach it thoroughly. Thank you.